A very good afternoon to everyone. I'm going to present my work on the prevalence and genotyping of Acanthamoeba species in a keratitis patient from Tertiary Care Center of North India. This study was conducted in the Postgraduate Institute of Medical Education and Research. Coming to the brief introduction, Acanthamoeba species are increasingly recognized an important microbe because they play an important role in the human pathogen and cause serious infection and environment. It is a ubiquitous in nature and isolated from several habitats, including the domestic tap water, swimming pool, soil, and dust. Clinical manifestation of these includes granulomatous amoebic encephalitis, cutaneous lesion, and sinusitis in case of immunocompromised individual, whereas in immunocompetent individual, it causes Acanthamoeba keratitis. The brief life cycle that Acanthamoeba consists of two stages, trophozoite and the cyst. Trophozoites are the infective stage, whereas cysts are airborne which spread Acanthamoeba into the environment. And Acanthamoeba can enter through eye, then it results in the keratitis. When it's entered through the nasal passage to lower respiratory tract, then it invades the central nervous system, causing encephalitis. And when it enters through the skin or broken skin, then it causes the cutaneous acanthamoebiasis. Keratitis is the eye infection in which inflammation of the cornea, and it is categorized into bacterial, fungal, viral, and parasitic. And today's seminar is focused on the Acanthamoeba keratitis. Acanthamoeba keratitis is a serious sight-threatening disease, which is characteristic feature is typical ring-like infiltrate and intense pain. More than 80% cases occur in contact lens wearer in developed country, whereas in developing country it is due to the corneal injury. And in India, it is uncommonly related to the contact lens and however mostly occur after corneal trauma or exposure to the contaminated water. Epidemiology ranges from 0.1 to 3.06 per 10,000 contact lens wearer across the globe, and at present 120 million people wearing contact lenses in the world, and in USA more than 85% cases occur in contact lens wearer. An Indian scenario, there is only 2 studies from South India and there is no study from North India, in which they reported 7 cases of Acanthamoeba and 1 case is from bacterial and co-infection with the bacteria. And in another study, author reported that Acanthamoeba comprised 1% of all the infectious keratitis case and 2.8% of all the culture positive cases, and 0.9% of occurrence among the contact lens wearer. The risk factor contributing to Acanthamoeba keratitis is swimming while wearing the contact lens, using domestic tap water, working with the soil which leads to the corneal injury, water-related activity, and poor hygiene practice of contact lens. Diagnosis of Acanthamoeba keratitis is not straightforward, and it relies on microscopy, culture, and molecular techniques. The specificity of these techniques is 100%, but sensitivity varies. Microscopy has sensitivity of 30 to 40%, whereas culture has sensitivity of 73%. Culture acts as a gold standard, but it is a time-consuming which delays the treatment. So molecular techniques are now emerging an effective tool and have shown high sensitivity like 90% for PCR and 97% for real-time PCR. Acanthamoeba genotyping is a useful tool for studying taxonomy and epidemiological relationship. And based on 18S rDNA gene sequence, the Acanthamoeba is divided into 19 genotypes, that is from T1 to T19. And subset of these 18S RNA DNA sequence has been accepted for the genotyping by JDP1 and JDP2 primer. However, in order to reduce the time and expense, targeting to highly variable region designated as diagnostic fragment 3 were used for sequencing. With this background, the aim of the study was to study the prevalence and genotype of Acanthamoeba species in a keratitis patient from a tertiary care center of North India. Methodology, that 265 patients with microbial keratitis plus 25 healthy control were included in study, and they were grouped into 3 groups. Group 1, group with 240 patients with microbial keratitis, group 2 with confirmed cases of bacterial and fungal keratitis, and group 3 with healthy control with no symptoms of keratitis. And samples were processed for microscopy, culture, and molecular techniques. In microscopy, GIMSA and calcofluor staining was done. For culture, non-nutrient agar culture was done. And for molecular diagnosis, DNA was extracted from phenolchloroform isomile method, and then PCR was performed using following conditions. And then real-time PCR was performed targeting 18S rDNA using following primer to obtain the amplicon of 180 base pair using cyber-green test. And this table showed the real-time PCR amplification condition. And to determine the analytic sensitivity of PCR and real-time PCR, first the serial dilution of genomic DNA was done, and then quantification of genomic DNA was determined by nanodrop, and then initial concentration was made to achieve 100 nanogram per microliter, and then tenfold serial dilution was made from 100 nanogram to 1 femtogram. For analytic sensitivity of PCR and real-time PCR, the PCR performed on the confirmed cases of bacterial, fungal, and TL sample, and on other parasites. So assay can detect only the Acanthamoeba. For genetic characterization of Acanthamoeba isolate, a direct sequence of the PCR product containing diagnostic fragment 3 was performed using following primer, and then multiple sequence alignment was done by using cluster W software, and phylogenetic tree was constructed using Megha. Coming to the result, corneal scraping was obtained from 221 patients, and 1 were found to be positive by microscopy, and 3 were found to be positive by culture, PCR, and real-time PCR. Bandage contact lens was obtained from 19 patients, and 1 were found to be positive by all the techniques, whereas lens case were obtained from 6 patients, and 1 were found to be positive by culture, PCR, and real-time PCR, whereas no result were obtained from any contact lens solution, and TL sample. Now coming to the case, the first case is the 60-year-old female with agriculture background and presented with the declared oxygen vision, redness and watering eye, and history of trauma with the wooden eyes. And initially it was treated with antibacterial, but after the confirmation of the Acanthamoeba, then it started treated with the polymyxin. But there is a totally perforation of the cornea, then patient underwent the surgical intervention. Second case was a 72 male with agriculture and had history of trauma with vegetative matter, and initially it is treated with the antiviral. And after the confirmation, then it is treated with the polymyxin and patient is cured. Another case in which there is no history of trauma and contact lens, still there is appearance of the ring-like infiltration with epithelial defects. And another case was the contact lens wearer, where he keep his contact lens in domestic tap water. And another case, and after the post-operative surgery of keratoplasty, the multiple epithelial pearls were found. So we are able to save 5 eyes. This picture is showing the corneal ulcer, and this before the treatment, and this is after the treatment. This picture is showing the Acanthamoeba trophozoite cyst by non-nutrient agar, and this table is figure gel picture is showing the PCR amplification with JDP1 and JDP2 primer, in which lane 1 depicts the molecular marker and lane 2 depicts the lane 2 to 6 depict the corneal sample positive for Acanthamoeba, and lane 7 positive negative control and 0.8 positive control. And analytic sensitivity of PCR found to be at its amplification from 1 picogram of the DNA, which is equivalent to the single Acanthamoeba. And analytic sensitivity of real time was found to be that it can detect 100 femtogram of the DNA, that equivalent to 1 copy number of the 18S RNA gene. And this table is showing sensitivity, specificity, positive predictive value, negative predictive value, in which the specificity of all the tests were found to be 100%, but sensitivity of microscopy is 20%, culture 100, and molecular technique also the 100. So disease prevalence was found to be 2.08%. And phylogenetic tree reveals that our isolate fall into 3 clades. Clade 1 represent Acanthamoeba castellani, clade 2 represent Acanthamoeba hutchiti, and clade 3 represent Acanthamoeba lenticulata. So 2 isolates were representative of T4 genotype, in which there was history of trauma, 2 were from contact lens wear, and 1 which is representative of T5. Now coming to discussion, this table is showing the study across the globe. In one study, conducted by Bhutan et al. In Hong Kong, they found 20 isolate. 15 were T4 and 5 were T3. Another study from USA in which they found 16 isolate and 13 was T5, 13 was T4 and 1 was T5. And only study from South India in which they found T4 isolate, and in our study we found 5 isolate. 2 represent the T4 genotype, 1 represent the T5 and 2 represent T11. Conclusion: genotypic identification obtained in this study of Acanthamoeba isolate from Acanthamoeba keratitis confirmed the T4 as a predominant genotype, and there is no study from North India regarding Acanthamoeba genotyping from Acanthamoeba keratitis, and this is first study from the India which report T5 and T11 genotype from Acanthamoeba keratitis patient. Acknowledgement: I want to acknowledgement for my guides giving me valuable suggestion, and Indian Council of Medical Education, Medical Research for providing me funding. Thank you for your kind attention.
Thank you very much. Has anybody any questions?
I do have a comment, actually. It's not a question. I do appreciate your work of hitting such sensitive topic. Second, your presentation and your engineers are very nice.
Thank you.
Appreciate it.
Any further questions? Okay, I've just got one question. So, do you know anything about the distribution of these genotypes globally? Is there any pattern to them, or?
Across the globe, there is T4 genotype, which is prevalent.
It's the most common, yeah.
More, because it is found in environment also and in the Acanthamoeba keratitis, because most of the people use contact lens for using domestic tap water. So this is the main reason. That's why from environment we are getting directly disease.
Okay. So there's no particular pattern about genotypes in different locations that you know of?
In different...
So in different geographical locations, there's not a difference in the distribution?
No.
Okay, any further questions? Okay, thank you very much.
Thank you.